Speaking with us, we have the Shadow Secretary of State in Health and Care, Wes Streeting. He's going to be in conversation with Quilter-Pinner, who is Director of Research and Engagement at IPPR. But before I hand over to them, I'm going to welcome Chris Thomas up here. So Chris is Head of the Commission on Health and Prosperity at IPPR. He's going to tell you a little bit about the work, and then we'll go over to Wes and Carey. Over to you, Chris.
Hi everyone, I'm the support hat today. I just wanted to give a little bit of context to the Commission on Health and Prosperity, a cross-party independent initiative, some of the research that it's been doing, some of the results it's generated, just to inform some of the conversation that will appear in just a couple of minutes' time. And the theme of what I want to share was the crossroads that the country stands at, the crossroads in terms of the National Health Service, but also a crossroads in terms of public health. But before I do that, let me just share the hypothesis of the Commission on Health and Prosperity, and that's that a healthier country is a fairer country, something that is studied a fair amount, but then in turn, a healthy country is also a more prosperous one, something that receives less attention, that is a less focused issue in terms of how we approach our economy and building a fairer economy. So there are two major interventions from the Commission I want to draw on. The first that looks at the nature of the relationship between our health and our economy. And we looked at what happens to people, just the simple question of what happens to people over a number of years if they fall sick. And that could be a mental health condition or that could be a physical health condition. And the really startling thing we found is that the impact of the onset of sickness on someone's economic life, their economic prospects, is incredibly profound. So the onset of sickness predicts a very large increase in the chance of falling out of the labour market. It makes it much harder if you're not in work to find good work. And I think most profoundly, it decreases people's earned income to an extent that if we were talking about a healthcare bill in the United States, we'd be talking about catastrophic care costs, so something that's really, really big. Now, we have projections suggesting that sickness is going to rise incredibly high in this country. So the Health Foundation predict 9.1 million people will have a major condition by 2040. And that means that if we don't have a foundation of health, that we are very likely to have a good foundation for the kind of economy we want to build, both in terms of growth and its overall prosperity, but also because of health inequality is the foundation for a fair economy as well. The second piece I wanted to just talk to that, again, indicates this crossroads that we stand at is a piece that we put out 3 weeks ago on the future of health and social care services. And we wanted to understand what would it look like if we continued on our current trajectory in the NHS and adult social care versus a more reforming kind of trajectory. And what we find is that looking at how things have changed since the pandemic, looking at the red lights that are flashing on the NHS dashboard, not social care's dashboard, that if we continue going with the status quo, the way that things are working at the moment, we risk, one, outcomes for people, service users and patients being incredibly poor, but we also risk the cost of services being incredibly high. So our projection comes down that healthcare expenditure could rise from about 9.5% of GDP today to about 11.2% in just 10 years. It's a massive rise. So an extortionate cost for subclass services. And we set out a plan to reform health and social care based on shifting towards prevention and productivity that, if implemented, we find would not only increase outcomes for patients and service users, but would actually mean we have sustainable finances as well. So there is still a vision there that works for both public health and for public finances. It just takes courage and commitment to get that bold policy. So on that note, we're delighted to see the kind of level of commitment to mission-driven work on health that we've seen from the Labour Party, because it feels like the time is now that if we want good health, a strong economy, good public services, that action is desperately needed, a real defining moment for the UK, for its people and for its economy. So a little bit of context from us. You can find all our reports on IPPR's website, but I will not delay us from hearing from Wes any further. So thanks very much.
Welcome everyone, and we are delighted to be here today. I'm delighted that Wes is able to join us Just to say that we will, Wes is going to do media rounds, so we're going to keep this to an hour, and we will do a bit of a conversation between myself and Wes first, and then I will open up to questions from the audience. Do you get your questions ready? That's great. Sparking is great. Is awesome. What's sparking? Health secretary and a waiter as well.
DJ and...
I'll let you finish.
No, don't let me stop you saying nice things.
So, Wes, I wanted to start, if I can, on a bit of a personal note, because obviously you spend a lot of time talking about the politics, and we'll get onto the politics and the policy. But I think we also want to get to know the Labour frontbench as people, and I'm struck that it's only relatively recently that you were diagnosed with cancer. Delighted that you're fighting fit now, and I wanted to maybe kick off by asking, tell us a bit about that experience and what you take from your experience at the NHS through that period, how that motivates how you'll approach being health secretary, what you learn from that.
Yeah, well, and firstly, thanks very much for hosting and for the contribution that IPPR has made to the intellectual renewal of the Labour Party and helping us to provide an evidence-based approach to how we tackle the multiple crises that are currently affecting our country and putting us in a position which we find ourselves in this week here in Liverpool, where we've got not just a leader and a team, but a plan that can give Britain some hope back, that politics can be part of the solutions, not just part of the problem, and in doing so, to give Britain its future back. I'm on commission for every time I mention the conference slogan. So in all seriousness, thank you. It's a funny thing to say for someone who received a cancer diagnosis when they were 38, but I was incredibly lucky. I went into accident emergency department about 4 o'clock in the morning on budget day, so missed out on the excitement. I'm one of those sad people that gets really excited about budget day. In fact, one thing I didn't include in my book, because I just thought it was too tragic, was that I used to bunk off school on budget day. I know. Honestly, I did confess to being a massive Star Trek fan, so you can just see why I was bullied at school, really. So I shouldn't say, I'm going to get so much trouble for saying that now too. There I was in A&E, excruciating lower back pain, and I didn't have actually a bad experience. I went through A&E relatively quickly. They gave me all sorts of painkillers, pain relief, and I received a scan, an ultrasound scan, that identified that I had kidney stones, which it turns out more painful than kidney cancer. And it was in the process of identifying the source of the pain that I was experiencing that they found a lump on my kidney. And so were it not for the fact that I had kidney stones, it is very likely I might be sitting here talking to you today with kidney cancer, completely unaware, and potentially thinking about this a couple of years on, metastasising, might be finally recognising that I'm a cancer patient because I've got secondary cancer, which have more symptoms and late stage, more tricky, treatment pathway much worse. So you can imagine how lucky I felt that it was caught early at stage 1. I was referred to the Royal Free because of the concentration of services during the pandemic, and I had treatment from one of the world's best kidney cancer surgeons using a Da Vinci robot. So I had cutting-edge robotic surgery, which meant I was out of hospital after 2 nights, back home, a bit of time off, and then came back to work cancer-free. All while that was going on, didn't have to worry about the bill, the advantage of the NHS that we have, and also didn't have to worry about work, which is another thing that made me lucky. There are people who go through that cancer journey on top of the worry about their cancer and their recovery and how their families might feel. They worry about their work, their income, how they're going to pay the bills, and I didn't have any of that worry. They sometimes have bosses that aren't actually terribly sympathetic and think, oh God, do we really want Do we want, do we want sick notes stuck around? Let's sort of, think about whether we can elbow them out, or maybe people might not have the employment rights that give them the security of work, and so they get elbowed out of their job. I had a boss who was really supportive, that not only supported me, but promoted me during my kidney cancer experience. So how lucky was I? It's a far cry, I'm afraid to say, from lots of people's experience, but it has certainly given me a warts and all experience of the NHS. I was lucky overall, but I had some feedback on my experience of mystery shopping on the NHS. And I'm afraid I've got lots of other family, my family's had quite a lot to do with health and social care for unfortunate reasons over the last couple of years, and I've got plenty of other anecdotes I could offer about how bad the NHS is, how poor the service is, and how far it has fallen from the founding principles and from its performance for most of the last 75 years. And I think that is a common experience, too common experience, which is shared by both patients and the staff who are working in it, which is why so many of them are experiencing that moral injury, and why so many of them are not just walking out on strike, but walking out of the NHS altogether. We've got a recruitment challenge in the NHS, but we've got a retention crisis too.
And, Labour has, if Labour wins, will, as you say, inherit a very difficult situation. And that's not the first time in political history that Labour has had to come in and fix services like the NHS before, obviously 1997. Similarly, a big challenge. Looking back at 1997, and I'm sure you were talking to lots of people involved in that period, what bits of the playbook that Labour used historically to tackle some of these problems, and maybe we'll park funding, I'm talking about reform, and I'll come to funding, I'm not going to let you go, that's talking about funding, but what part of that playbook do you think we can use again, and which bits of it do you think actually that work then, it's probably not going to work now, we're going to have to think about this differently?
Yeah, so I can exclusively announce that we will not be copying and pasting the 1997 pledge card, which said that we would sack some NHS managers in order to cut waiting lists by 100,000. How different things are today. NHS waiting lists are unfortunately going up by about 100,000 a month at the moment. So can you imagine how people would respond if we said, actually, we're going to reduce some pretty critical capacity in the NHS workforce and have such a timid ambition that we are just going to reduce the waiting list by a measly 100,000. Of course, we know the performance of that Labour government after 1997 was so much greater than the promise it made, which was fairly modest in 1997. And so if the pledges aren't identical, because the challenges have changed and so are the solutions that are required, I think there should be a similar approach, which is to under-promise and over-deliver. And I think that, I know you're going to press me on finances, the other currency that is in really short supply in our country at the moment is trust. And if there's one thing that unites the voters of Tamworth and Mid-Bedfordshire and Rutherglen and Selby and Ainsty, where I've spent a lot of time, as you might imagine, over recent months, and indeed the voters of Uxbridge, but it's that loads of people recognise the state of the country after 13 years of Conservative government. What lots of people are saying is things are so broken, can anyone fix this? So Labour's got to give people its hope back before we get a chance to give Britain its future back. And the way in which we do that is making sure that we have policies which are credible, which genuinely make an impact and are affordable. And as you saw from Rachel Reeves' speech yesterday, not a surprise that she is putting fiscal responsibility at the heart of her agenda, given what happened with last year with the disastrous mini-budget. We've got to make sure that we are making promises that we can afford, and so that concentrates our mind. The one thing I do reflect on a lot, thinking about how it was that the last Labour government delivered the shortest waiting times and the highest patient satisfaction in the history of the NHS, it was investment and reform that delivered those results. And I've deliberately elevated reform because I felt when I became Shadow Health and Social Care Secretary, you never have to persuade people that more investment is needed on anything. And actually the easy answer is always more money. The hard truth, though, is that there isn't a great deal of more money around. What I did have to persuade people of is that reform is necessary, and I have deliberately sought to shake the party and the country out of some of the rose-tinted, dewy-eyed nostalgia and sentiment about the NHS, and also so we can be confronting the reality of the status in today, and also shake people out of the complacency that had even some of the most modernising voices from the last Labour government saying to me privately, or don't use the R word, or everyone hates reform, it goes down like a bucket of cold sick, which of course is like a red rag to the ball to me. And I thought, well, if people aren't even prepared to talk about reform, we're not going to have a chance of delivering it. And I'm looking at this system, I'm looking at the diagnosis we've already heard this morning, and I'm looking at other countries that have far superior health outcomes, and I think, why on earth would we defend the status quo? And the Labour Party, at the heart of our politics, has always been reforming. We didn't come into politics, the party wasn't created to conserve, there was already a Conservative party. We came into politics to be the change makers, the people to disrupt the consensus and status quo, and to share power, wealth and opportunity, and to break the status quo that tends to disadvantage the many and benefit the few. That's what our politics is all about.
And just to kind of push you a bit more on some of those reform mechanisms that the new Labour project lent on, just to get your take. New targets in the system, use of targets, and what about kind of choice of competition? The internal market is obviously a big part of what New Labour pushed on, and there's Tony Blair Institute out again recently saying that's exactly what you should do again. What's your take on that one?
On targets, I think you definitely need to have clear goals. What's measured is what counts. They need to be smart targets. There's always the laws of unintended consequences, so I think we have been thinking very carefully about our goals. And one of the important things about the mission-driven approach, which Chris has already referred to, and is a big part of Keir Starmer's personal governing philosophy, is you set a big mission with clear outcome-driven targets, and therefore you get this enormous system that just in the NHS has well over 1 million people working in it. You get that system geared towards those goals in partnership with the other partners you need to deliver the kind of change we want to see, which is not just about improving the diagnosis and treatment of sickness, but actually preventing illness and promoting good health, which is a challenge and a mission that goes well beyond the capabilities of the NHS, even at its best, well beyond the capabilities of the Department of Health and Social Care, even at its most powerful, because if you're serious about building a society where people live healthy, happier lives, and don't just live longer but live well for longer, well, that's a mission-driven approach that requires every government department to pull together in pursuit of that mission, working with business, working with civil society, and crucially working with us as citizens, as patients, and giving us more agency, power and control over our own health, our own care, our own choices, our own lives. That's how you end up with, not just an NHS that's back on its feet and fit for the future, it's how you end up with a fairer, more equal, more just, more happy, more healthy society. Because as Michael Marmot has spelled out for us in stark terms, we are not going to succeed in those big missions and big ambitions that Keir set out in his speech in Essex earlier this year, unless we are also tackling the social determinants of health in our country, and that's things like housing, good work, education and skills, sport and physical activity and access to culture and art and all of the things that make life worth living. So it's an exciting agenda, it's a bold agenda, and it's one that we're going to have to work in partnership to deliver. And just on choice and competition, that's where, I was never persuaded that competition within public services is the key driver to improving public services and improving outcomes. And the more and more I look at this NHS we have today, the more I think the key is actually integration and collaboration rather than competition. There's a place for competition, but I wouldn't kind of elevate it to be the central driving kind of governing philosophy of our public service reform agenda in health. You know, there may be other areas where colleagues will take a different approach, but in terms of different horses for different courses, some competition, certainly a big place for choice and patient choice and patient power. But actually what I'm thinking about is more integration and collaboration and partnership.
And you talked very eloquently over the last few years about the shift to prevention, the shift to moving resources into the community, into primary care as the driver, and there's a huge consensus, which I feel I'm part of, that says that's the way to go. Successive health secretaries have stood up, health and social care secretaries I should say, we always forget social care.
I don't.
Very, very, very good. We'll hold you to that. It's been said for decades. Getting it to happen seems to be really tricky. How are you going to approach that? How are you going to make sure that the centre of gravity that always sits around hospitals and the acute sector, both political gravity, because of course putting resources somewhere else means taking it from hospitals, for example, but also the systems gravity, a loads of acute doctors, very powerful trust chief execs who are phoning you up and saying we've got a problem. How are you going to change that record of saying one thing but failing to be able to get that money and resource to shift into a different place in the system?
I think what's different about the moment the NHS finds itself in is lots of those acute trust chief execs recognise that solving their problems necessarily means fixing other people's problems first and foremost, in a way. If you want to unblock big acutes, you need to deal with delayed discharges at the exit door. That means better social care and more social care capacity. If you want to stop your accident emergency departments being overwhelmed with people who really ought to be seen elsewhere in the system, well, that means fixing primary care, dealing with the excessive workload and under-doctoring in general practice, making sure the community pharmacy is helping them in turn to play their part, creating more front doors to the NHS in primary care through new services, and Labour's mental health, community mental health hubs are a good example of what a new and different service approach might mean. In fact, the best trust chief execs are already voting with their feet and showing us as what's possible. When I went up to Leeds General Infirmary with Rachel Reeves, I always try and take Rachel out with me on visits to say, oh gosh, Rachel, look at the state of that ceiling. And
it's expensive.
Yeah, well, Rachel, look at these, it's really under-doctored. Wouldn't it be great if we doubled the number of medical school places? Hint, hint. It works to an extent. She's as ruthless privately as she is publicly. Rachel and I were both very impressed that the approach that they took in Leeds was to say, we've got this massive delayed discharges problem. We need to spend some of our budget through our partners in social care to give them the capacity they need to help us out. And, when you make those sorts of decisions, it's amazing how insular and narrow-minded people can become. Because you get some people saying, well, hang on, that's not our job and that's our money, we shouldn't hand that over to someone else. Or even if people are a bit more strategically minded, they'll say, oh, hang on a minute, but from a governance point of view, we're accountable for this money. We're going to have problems with this as a board, for example. But the best leaders and system thinkers are the ones who've made a more courageous call of saying, hang on a minute, what do we care about first and foremost? Patients. Getting them the very best care in the right place at the right time. And just as important, we're responsible for spending taxpayers' money wisely. And so the decision that in Leeds' case they made to spend taxpayers' money that had been given to them for their duties through partners in social care meant better experience for patients, but better use of taxpayers' money. And it's why the reform arguments I'm making are, of course, primarily about better experience for patients, right care at the right time in the right place. But it's also about spending taxpayers' money more wisely, because the worst thing that I see in the system as it is today in the crisis, that it's not only worse for patients, it's worse for the taxpayer. Because someone can't get an appointment in general practice, there are thousands fewer GPs than there were, they end up walking through the door of A&E and waiting there for hours on end. Not just worse for the patient, more expensive for the taxpayers. Instead of 40 quid for a GP appointment, it's cost 360 quid for an A&E attendance. So the system we have is wasteful in every sense, and that's why Rachel and I aren't prepared just to pour ever-increasing amounts of taxpayers' money, which is in short supply, into a broken model that will see that money wasted and patients still not getting the care they deserve. And that's another driver for me behind the importance of the reform agenda we've been spelling out.
I'm going to open up to questions in one moment, so do get ready. Final question for me, you brought it nicely around to money, which is where I was heading anyway. I'm not going to ask you the standard question of aren't you just going to spend a little more money, because you're giving the standard answer, and we've heard it before. You're very disciplined, Wes, which is probably to your credit. But I will ask you, you will end up in negotiations with the Treasury at some point about more resourcing, however much that is. How do we make the case for health spending and going forward? There's always this default, and the Treasury, not necessarily Rachel, but the Treasury in general, always takes this view that it's kind of a kind of bottomless pit that it is a drain on our national resources. Can we pivot? Can we persuade Rachel? Can we persuade the Treasury that actually this is an asset that we should be investing in? It's health is part of the thriving economy that we're aiming for. How are you going to persuade Rachel when you get to that point?
Yeah, and it's going to take more than my sort of usual witty repartee with Rachel and offering to carry her bags and make her lunch and lie down in puddles so she can walk over without getting her feet wet. There's a serious point here, which actually I'm glad you've sort of taken it to, I think, a more deeper challenge for the NHS and the Department of Health and Social Care, which is the worst kept secret chronicle of the appalling relationship between the Treasury and the Department of Health and Social Care and NHS England. There just isn't the trust there on the part of the Treasury, which I think it can in part sometimes be due to a very short-termist mindset within the Treasury as an institution, which is something I observed during 4 years on the House of Commons Treasury Select Committee. But actually, that's not my responsibility and won't be my department if we win the next general election. My responsibility is to really get into the core issues as to why the Treasury is legitimately sceptical about the Department of Health and Social Care and NHS England. And having been, as I say, on the Treasury Committee for 4 years and a member of the shadow Treasury team when Keir first became leader, if Rachel and Darren, and before Darren Pat, had £1 for every time someone came along with a really great investor save proposal, they could personally fund the NHS and have enough money left over for the Dean Harvey's tax bill. I think there is a legitimate degree of scepticism. The argument I'm positioning is, firstly, the role that I have now and the role that I want in government is, of course, a public service role primarily, but actually it's an economic portfolio. Because the health of the nation and the health of the economy are directly linked. And you guys at IPPR have been at the forefront of the pack making this case. And if you want greater productivity in the economy, if you want to get Britain's growth back, you've got to get people off waiting lists. You've got to deal with the physical and mental health challenges in the country so that people are fit and healthy and happy and motivated. And there is no route to economic growth that doesn't involve lower waiting lists. I thought it was music to my ears at the weekend. So I was doing wingman duties for Keir on Sunday. He was doing the Laura Kuenterberg programme in Victoria, Derbyshire, and it was my job to do the rest of the Sunday morning round without saying anything contradictory or remotely different or abstracting from anything that Keir says, which is more pressure than you might think when you're live on television or radio and you're not able to sit there and watch what the boss is saying. But luckily, because of the strong message discipline and team spirit we have built, I passed and have not been fired, so that's always good. What was great was, in advance of the Sunday morning round, they were talking me through what was going on. I knew that Keir was doing the waiting list announcement, 2 million more appointments, £1.1 billion going directly into the pockets of NHS staff to help us deliver more evening and weekend working to see gets patients seen, but alongside Bridget Phillipson's skills announcements about how to make sure that vocational and technical education is more directly linked to the needs of local regional economies. And so the whole thing was being packaged together as growth announcements. Fantastic, great. So I think we're winning that argument in broad terms. What I need to do is make sure that every penny of taxpayers' money that's going into the NHS in particular, social care is not a different kettle of fish, but every penny that's going in already is money well spent before Rachel or Darren will accept the case for more greater spending.
I'm going to open up to questions. I haven't mentioned social care, so if someone doesn't ask a social care question, I will take the liberty again to ask a social care. I'm going to stand up so I don't just get people at the front. The lady here in pink, just here, fourth row.
Oh, it's red.
Red, sorry.
Thank you. Shall I start?
Yes, please.
Hello, hi Wes. It's Fiona Loud here from Kidney Care UK. Thank you for being again so open about your kidney health stuff. So, may I ask, how would a new Labour government address the long-term mental health needs of people with conditions such as kidney failure? We have those demands that go right across the whole spectrum, from prevention to the fact we now have a 10-year high of people waiting for a kidney transplant, yet our staff often don't know how to deal with it. We provide counselling services ourselves at the charity, but we cannot replace what the NHS does, and it's a very variable sort of support that people in the situation I've just described give. So perhaps you could comment on that. Thank you.
Yeah. Do you want to say a couple?
Yeah, we got.
Yeah, okay, we'll get a few. The lady in the striped jumper, just here.
Lucky me. Hi, I'm Jennifer from Community Leisure UK. Wes, I loved you talking about social determinants of health and specifically mentioning sport and arts and culture. Wales has a great scheme, it's called National Exercise Referral Scheme, and a lot of exercise referral is happening in England as well. There's lots of research about the benefits of social prescribing. So what's Labour's plan for a more systematic approach to exercise referral and social prescribing across the country?
And I'll take one more, the lady just here in the front. Hand up. Keep your hand up, so yeah, I feel no too. Yeah. Thank you.
Thank you. Hello, my name is Emma I'm from the Hendon CLP. As a taxpayer and user of the NHS, it's great to hear you talking about patient power and reform. I'd like to ask a question on behalf of friends who are junior doctors and my sister who's also going through medical school. What is Labour going to do about addressing the bottleneck in training for junior doctors then going on to specialty practice or core training, because there are people who want to stay within the NHS but they can't progress on to the next level. Thank you.
So we've got some good topics. They've got mental health, social prescribing, and junior doctors.
Yeah, I'll try and be uncharacteristically brief so we get more people in. Let me take the last one first. Absolutely conscious of the bottleneck issue and the importance of career progression. It is a very good example of the number of issues which are not directly pay related that a competent and professional government might negotiate with the profession on in order to end strikes that are by far and away at the moment the single biggest challenge in the NHS on top of everything else. And as people have heard me say, I think the challenge is that Rishi Sunak has decided that he won't meet his pledge to cut waiting lists for reasons of government incompetence and failure, and has chosen to scapegoat doctors instead. and fuel the retention crisis, which is both short-termist, irresponsible, and deeply cynical. So I recognise these wider issues about people's working conditions and career progression opportunities, and often the posts they want to progress into are posts that are in short supply and are part of getting people not just diagnosed more quickly, but treated more quickly. So we're actively looking at it, and I know that when we announced doubling medical school places, the reaction of lots of parts of the workforce, particularly the junior doctors, was, well, look, we know we've got an understaffed NHS, it's great, but actually what we're hearing is, oh no, even more competition for the specialist training places. And so, we don't want to pit people against each other. We do need a better staffed NHS, but that means not just recruitment in medical school places, but further progression is something we're actively looking at in terms of longer term workforce planning. On social prescribing, I am a fan of social prescribing. I think we've got to see people's recovery and also future prevention and keeping people out of hospital as being about more than pills and more than jabs and drugs or surgery, but is about things that will keep people fit and active and well and rehabilitated. And from my own perspective, thinking about kidney, my kidney health, I have taken things more seriously now than I did before. The difference is, I'm on a salary where, I can afford a gym membership. And it doesn't look like it, but, honestly, it's made my heart attack less likely if my future career as an underwear swim model has been ruined by both, a bit of the gut line and also my kidney scars. Life's hard for me. And also swimming memberships and things that actually, I think my swimming membership costs 30 quid a month, so it's actually quite reasonable in my local council, but 30 quid is a lot of money when you don't have it. And then you link, you link poverty and obesity and chronic disease, and lots of these diseases are themselves crises of poverty, so we've got to make sure that sport and physical activity is accessible and affordable. What we've got to be a bit careful though, is not going too far on seeing the NHS as prescribing a whole load of things that frankly ought to be picked up not just by other parts of the public sector, but by getting the underlying unfairnesses and injustice of the economy, particularly in terms of work and pay. We've got to deal with those issues. What we can't have is, because the state is broken, the NHS becoming the state, the whole welfare state, because I think that will undermine the future sustainability of the NHS and public support confidence for it. Finally, we've got to start thinking much more about whole person care. And I'm afraid that partly because of resource constraints and the fact that, to be honest, when you've got someone, patient sat in front of you and you're thinking about their, in my case, kidney pathway, there often aren't services for someone to join up and refer into in relation to mental health. But I think there is just a bit of a problem where, that because there's a lack of services and a lack of direct solutions, what you end up with is just a sort of, oh, well, of course you're going to suffer with depression because it's pretty miserable what you're going through. As if that's just something you have to accept and live with, as if it should be a normal part of a difficult physical health pathway, healthcare pathway, that you would just necessarily have a mental health crisis or illness on top of it. That's the culture we've got to change. We've got to make sure the services are there to join up with and refer into. And we're making a start on this, and this is why, in terms of managing expectations, having credible policies, we are talking about a 10-year plan for health and social care. It took the Tories more than a decade to break the NHS. It's going to take us more than a decade or at least a decade to get it to where I would want it to be. But we've got to recognise the importance of whole person care, and not just parity between mental and physical health, but the direct link between physical and mental health too.
Thank you. Right. Number three, the lady in the centre just here.
I have a social care question.
Hi, Wes Streeting. I'm a pharmacist. Now, Rishi Sunak constantly talks about his mother being a pharmacist in every campaign that he runs. Yet, under the Conservative government, thousands of pharmacists have closed their doors for good, mainly in areas of deprivation. So it would be very helpful to understand what Labour's plans are to save our local NHS pharmacies.
I don't want to encourage shouting out, but the lady with the social care question.
Thank you very much. Councillor Dr. Erica Lewis, I'm the Shadow Cabinet Member for Adult Social Care in Lancashire, where you'll be astounded to discover the Conservative administration says there is no unmet need for social care. Astounding. I understand the need for fiscal restraint, I really do, but at some point we are going to have to talk about the finances of adult social care. Increasingly I talk to people who have declined social care packages that they really need, because the people that show up on their door, they're not prepared to do intimate care work with their loved ones. And so we have to think about the skills and the training and the professionalism of that sector, because we tend to think of it as being unskilled work, but actually it is incredibly skilled work, and it is some of the most important work that is done in our community. And we're going through the integrated care partnership work, and we've got a timing problem on that. We spent 13 years cutting prevention, and so now we're asking the NHS, local government and the community sector to rebuild prevention and wellbeing, but they don't have that money anymore, and it will flow through to savings eventually in both health and social care, but not all at the same time. So at some point we do need some funding for that prevention work to flow. But the social care finances we really do have to look at. Thank you.
Thank you.
I really want to counter that.
And I'm not going to encourage shouting out, so the gentleman in the middle just here, with the... Yeah, that. Sorry, I keep doing people in the middle, which makes it...
I wanted to see the row between the audience.
Hi, James Maxwell, Senior Policy Advisor at Sensitive Health. We currently face a public health emergency. It's one of the front doors to the NHS. The government's answer was to abolish public health in England in response. What's your plan?
So, pharmacy, social care, and public health.
Yeah, on social care, I mean, where we will start is the workforce, because I think the public understand very well that unless we have the ability to recruit and retain the great people we need, we're not going to provide the quality of care that people deserve. And the truth is that for many years now, we have undervalued, well, not just underpaid, but, really undervalued how difficult and professional the job that care workers do really is. And so we've got a commitment to introduce new fair pay agreements in different sectors of the economy. And it says something about Labour's priority and Angela Rayner's personal priority as a former care worker who might well become our Deputy Prime Minister if we win the general election. Angela has lived this, experienced this, and identified social care as the first sector in which we will introduce new fair pay agreements, which is an enormous opportunity for us. Alongside better pay, I think has got to come professional status, career structures, and recognition, so that social care is a profession that people aspire to be in and are proud to be part of. I think lots of care workers are proud of what they do, actually, but I think they're really frustrated that people don't seem to really value them and understand how difficult it is, and how rewarding it can be when good care really goes right, as it does despite all the challenges. On pharmacy, I know it's going to come as an enormous shock to everyone that Rishi Sunak says one thing and does another. I know, right? The revelations we found here this week in Liverpool about the Conservative Party. I think there is just a complete disconnection between the government's laudable ambition to have pharmacy first and for people to finally recognise the person standing behind the counter isn't just there because they're really good at counting pills and putting them in boxes, but actually because they are highly qualified experts in healthcare and can do actually quite a lot of diagnosis and treatment and prescribing. So I want to see a greater role for community pharmacy. I think it'd be great for patients, great for our high streets, and great for poor old GPs who, despite providing 1 million more appointments appointments now than they did before the pandemic are still picking up the newspapers and being criticised quite heavily because they can't meet the demand. So, I've been doing a lot of community pharmacy visits, working with national representative bodies to look at how we rescue community pharmacy and stop the slide. And part of that is trying to get this government to do more with the time they have left for the general election, so that we don't inherit an even worse situation than we currently have should we win the general election. Finally, on public health, I did public health in local government before I became an MP. I'm desperately anxious both for social care and public health about the state of local government and local government finances. I've seen public health budgets squeezed. I've seen provision withdrawn, which is worse for the public, but also more expensive for the NHS, picking up the cost of failing to prevent chronic disease or sexual ill health and all of the other fantastic work that local government public health at its best does. So we're looking at the moment at what more we can do beyond that, which we've already committed to in terms of things like junk food, advertising bans, tackling the outrageous behaviour of the vaping industry, inspiring the Prime Minister to act on stopping the start so that this generation of children growing up are even less likely to smoke than they are to vote Conservative. We need to think about other prevention services we can have in the community.
Right, I'm going to take one more round. So the lady just right by you, yeah?
Thank you. Eliza Park from Pulse Magazine. You mentioned poor old GPs just then. I wanted to ask about the GP partnership model, because earlier this year you said you wanted to tear up the GP contract, but you then said you'd be open-minded about it. What is your plan for the GP partnership model? Do you want to phase it out and bring in a salaried service?
Just remember, that was an IPPR policy, that one. Yeah, so my fault. The lady just here.
Hi, I'm Parita from Nesta. We're an innovation foundation looking at obesity. Given that diet-related ill health is a really key contributor to ill health, and I know you mentioned the advertising policy just now, but I'd love to hear more about what bold policies you really want to put in place to tackle the food system that really have that evidence behind them beyond kind of information. And yeah, really great to see prevention back on the agenda.
The gentleman in the middle, Joe, can you put your hand up so Joe can see? Yeah, great.
Thank you. Prevention seems very close to your heart, Wes. You mentioned it, it's the plans. When it comes to the NHS, my perception is that NHS is very good at late-stage care. It's not great at it, it's not bad at it, but it's something that... When it comes to prevention, I don't think it believes in it, and it seems a real problem. So my question is quite simple, two questions. One is, how are you going to overcome that culture in the NHS that's going to recognise prevention and take it seriously? Until it believes in it, I don't think it's going to happen. And secondly, where would you sit prevention? Would you sit it in the Department of Health? Would you sit it in the Treasury? Would you sit it in number 10? Well, clearly, as you said earlier, it spans right across the whole domain, being able to shape patients' behaviours.
I'm going to abuse my position chair to ask you a fourth and a final question for today, which is, there are groups, this is not an election-winning topic, but there are groups that are...
No, in that case.
There are groups that consistently suffer worse health outcomes, much, much worse. I'm thinking here of the homeless community, the BME community, you used to look at Stonewall, the LGBT plus community, trans community, really, really terrible mental health outcomes. What can we expect from Mabel on that?
Yeah, really great questions. Firstly, on the future of general practice and the GP partnership model, I've spent a lot of time on the front line this year with both salaried GPs and GP partners, really listening to what it is that, paradoxically, on one hand, leads to so many GP partners telling me how proud they are of the work they do, and how much value they believe they add to the NHS and, crucially, to patients. And yet, on the flip side, how it is that something that they are so proud of as so unattractive to new generations of people coming into general practice. And, you know, one of the things I think was sort of genuinely misinterpreted earlier this year was at no point did I say that we would sort of nationalise GPs or we would come in and just sort of axe existing GP partners. What we were minded to do is to sort of phase it out over time. I'm still not sure whether or not the GP partnership model can survive in the longer term, but I haven't reached a sort of firm conclusion that says that it shouldn't. And one of the things that I have recognised in the time that I have spent in general practice is how much added value GP partners provide, how deeply committed they are to their patients and to their lists and to their practices, and how GP partners, I think a lot of the GP partners take on a sort of broader leadership role in population health management and have a link to the community which has a longevity that I worry we might lose if we lost the GP partnership model. So I'm trying to think carefully about how we don't throw the baby out with the bath water, and you know, sort of recognise the system as it is, not perhaps as we would all wish it to be, and how we get it to a more sustainable future. So that's a long way of saying, you know, we haven't reached a firm conclusion about it. But what I can absolutely assure people of is that, you know, for existing GP partners, you know, they've got no reason to worry that we would come in and sort of, you know, tear up their contract or say that we're not having partnerships any longer. You know, I want to work with the best of general practice to reform the worst of challenges in general practice. And I hope that's reassuring to GP partners, and also shows that when I said we listen and consult and we're open-minded, that was genuine. On to the other questions. On prevention and where should it sit? Well, I think it has to sit in the Department of Health and Social Care. I think that the great opportunity we have with a mission-driven approach is something that's very personal to care, and therefore, if it is driven by the Prime Minister, it is much more likely to happen. So that's great for me, and there will be a mission delivery board which I am held to account, and every other Secretary of State and government department would be held to account to deliver on prevention. I think what we're trying to do with the mission-driven approach is to break the culture that I think you have accurately described, which is far too short-termist and short-sighted, dealing with the immediate challenge in front of us rather than making the right long-term decisions for the country. And the challenge is partly because of political cycles and partly because, you know, the change of personalities. I mean, we've had 4 health secretaries since I've been shadow health secretary. 2 of them have been Steve Barclay, and this one is even worse than the last Steve Barclay. So you can see how that political short-termism drives short-term thinking, short-term spending, and therefore waste of both money and potential and people's healthy life expectancy. So we are taking that long-term view, and that's why the commitment we've made to a 10-year plan for health and social care is really important. So glad you raised health inequalities. It is so important that we recognise that even within an individual condition, not everyone is the same, that people are affected differently, that there are deep health inequalities, and I hope we would all expect a Labour government to be focused on tackling the deep health inequalities and injustices that affect our society. So that will be a core part of our approach and thinking about service design and delivery and how we cater for unmet need in communities that are particularly disadvantaged. And it says a lot about Keir that one of the first things he did as leader of the Labour Party was commission Doreen Lawrence to look at racial disparities in particular. And I'm afraid it is shameful, particularly in relation to the NHS. How is it that in the year when we celebrated the 75th anniversary of the NHS and the whiplash generation that built the NHS, we see racism experienced by the staff who work in the NHS, And I'm afraid discrimination and inequality in the people that are treated by the NHS. We've got to turn that on its head and inside out. And Dory Lawrence and many others have given us lots of practical ideas and tools to do that job. I've missed a question. What was the one I missed? Diet-related illness. Yeah. So there's lots we can do. I'm really keen to look at what we can do with the food and drink industry, to whether it's on product reformulation, marketing. Crucially, I want to make the healthy option the cheap option. I think people have seen what I've said about things like buy one get one free deals or new taxes on a particular product. I don't want to make people's shopping more expensive. I don't think we tackle the health crisis by worsening the cost of living crisis. But beyond that, there's plenty of other things we can do, and we're in the market for ideas.
Thanks, Wes. Your chief of staff is looking very nervous on the side of the room. You're needed elsewhere. Look, thank you very much for joining us here today. And thank you, everyone, for coming. I hope you have a great rest of the conference.